I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor.
Welcome to another episode of Women's Health Unplugged. I am joined today by a colleague of mine, Dr. Fiona McCulloch, who's written the book, 8 Steps to Reverse Your PCOS. And it's a best-selling book on polycystic ovarian syndrome. We're hoping today to bust some myths about PCOS, but also talk a little bit about the future directions of where we're going in the research with respect to this condition, which is really the most commonly diagnosed endocrine disorder in women, which is why we spend so much time talking about it on the podcast and why it deserves so much airtime. Thank you for joining me on the podcast today, Fiona.
So nice to be here, and thank you for having me, Dr. Jordan. It's amazing to be here.
So I've been following you and your career for a long time, and was really excited when you published your book, partly because it came at a time where I don't think we were giving PCOS as much, I'm going to use the word airtime, as it maybe deserved, right? We were seeing these women in our office. We often as naturopathic doctors were like the first person to tell them that they had PCOS. And I'm maybe dating us back like 15 years ago with the two of us practicing, that we would often be that first touch point for women with PCOS. Whereas now I think we're seeing it get the attention that it deserves. But I would love to hear, and if we can start just by you sharing your journey for how you got to this spot in your career, why PCOS is such a passion project for you, and what you're up to as a practitioner.
Thank you. And yeah, I just want to say I've been following you for a long time as well, and admire all of the work you're doing in this area because you're making such a big difference for clinicians. For myself, I graduated in 2001. And I always personally had a lot of problems with my hormones growing up. I had cystic acne, and my cycles would come, maybe 4 or 5 times a year, very randomly. I was sent to dermatologists, given all kinds of antibiotics, taking them for months and months on end. These things would work for me, but nobody ever really dug into what was actually going on with my health. And so after I graduated, I did a little bit of work with my with lab testing and my doctor, and it did turn out that I have PCOS, which made complete sense given my history and symptom picture. But I think because at that time, as you say, it wasn't well known and it wasn't well understood, and all the different presentations weren't understood. And so from that point on, I became very interested in learning more about it. I realized it had a lot of complexities to it, and I find hormones really fascinating. I really like learning about them and how they interact with each other. And so, yeah, I just became super, super interested in that. And so from that point onward, I started to work a lot with patients with PCOS. I went on to have my own children, and in my pregnancies had gestational diabetes. The second one was pretty intense, and I was not fully diagnosed until the third one. So as a what would be considered lean PCOS, just got me very interested in the insulin resistance elements of everything, and just fueled my fascination with it more. So from that point on, I've just become fascinated with what causes it, how it presents in different ways. And so, yeah, that's the story behind why I'm so interested in PCOS.
Yeah, and it's interesting, and thank you for sharing your personal journey, which I didn't really realize that you had such a personal connection with the condition. I think that's common, right? That when you have that experience, then, especially when you have the background and ability to do the research and become well educated, that we get super passionate about the thing that we're afflicted by. But your story and your journey there is not that different than what we see other women experience, as far as they have these random symptoms, they see random practitioners. It takes a really long time for someone to tie that all together for them. And then even your experience with the gestational diabetes sounds like we were, things were maybe flying under the radar longer than it could have if someone was looking at your case through that correct lens.
Exactly. I had some birth complications because of that, and then figured everything out for my next baby. So yeah, it was flying under the radar, and it's very common actually that I found in my patients too. So I'm really passionate about pregnancy health, insulin resistance, and just proper detection and prevention.
So I think when women land in our office and they have been diagnosed with PCOS, because I'm seeing that more often, that people come with a diagnosis, whereas before it was like they had mysterious symptoms and I was the one maybe identifying them as PCOS. One of the first questions that they ask is like, why did this happen? What did I do? How did this happen to me? And what is our current understanding of that? Or what's your current understanding of what we think the origin or etiology of PCOS actually is?
Yeah, it's really interesting. I've been following this really closely. My undergrad was focused in biological science and in molecular biology and genetics. So I found this very, very interesting when I've been reading about this. It's research that's been going on for a few years on epigenetics and development in utero, and there are certain key stages of development for the ovary, the adrenals, and the brain that are influenced by hormones, endocrine disruption. And they've been able to induce PCOS in animal models by causing certain types of endocrine disruption at certain key developmental points in the adults, so all of this stuff turns on at puberty when those glands actually become activated. So a lot of the thinking now is that it's epigenetic, meaning that there may be some genetic tendencies, but these environmental influences prenatally are likely to be the underlying cause of many cases of PCOS.
And so by epigenetic, we mean that typically when we think of genetics, we think of things that are passed down like generation, over generation, and that it takes, I always think of bats when I think about genetics. I don't know why. I think about how many generations of bats it took for them to perfect their sonar situation that they have there. I think that's what people think when they think genetics, right? They think about evolution or things that change over thousands of years, but epigenetics is different, right?
Exactly. Yeah. There are some genetics involved in PCOS, but again, we're not that certain exactly because there's a lot of different genes that they have associated, but it's different in every study. This one's found in this study, that one's found in that study. There's one called DENND1A. That's a gene that creates androgen excess. And that one was found in one small study. I think it was 50% were positive for this gene. But, what they find is it's inconsistent overall, that we can't say, okay, this gene, causes it. But epigenetics are really when the genes actually have what we call methylation marks, meaning that there are methyl groups added to the gene that cause long-standing changes. And these methylation marks can be changed by the environment. So different things that happen in the environment will cause our DNA to change its function in different ways. So say, for example, a baby's developing in the womb and that baby's exposed to a lot of androgens at a certain time, that could change the way that gene functions in a longer standing way that would only be evident later on. So this is what they think seems to be one of the mechanisms behind the cause of PCOS.
Yeah. And I find that absolutely fascinating because when we start to back up and think big picture about, helping support prenatal health and why we find it so important that we, have those prevention strategies in place for pregnancy, why things like prenatal supplementation is so important, why smoking cessation is so important. So we're actually seeing that those behaviors in pregnancy are wiring the baby to be more susceptible to PCOS at a later date.
Exactly. Yeah. And it's so empowering because there's so much that you can do, sometimes people are like, well, we can't do anything about these endocrine disruptors that are just everywhere, plastics and chemicals, but there are a lot of things that we can do, by definitely taking the proper kinds of multivitamins, eating well, sleep, exercise, all of those things do make a difference. So it's very empowering rather than disempowering when you think about epigenetics.
I know. I agree with you. I think sometimes when we think about genetics, we think that it's like, that's your story, right? Like, and that's it. But there is that other side of it that like, by calling something epigenetic means that like, it's not that woman's fault that she has the symptoms that she has, right? That there has been, a wiring situation there that's made her more susceptible to struggle with PCOS. But also when we think about her future pregnancies and her future health, that we actually have the ability to influence like the next generation of women that are born to women with PCOS if we support them.
100%. And that's what I love so much about this concept.
Yeah, I find it so fascinating. And I do think that with the way that research is going, I think it's going to create a more like empowered prenatal situation for women with PCOS, where we typically have tried to get women with PCOS pregnant. I don't want to say at all costs, but we focused on the fact that they are not ovulating as like the sheer, like as the issue, right? And if we can have those women ovulate and have them get pregnant, conventionally, we've kind of like, washed our hands of the situation, push that woman on, and she may get diagnosed with gestational diabetes partway through her pregnancy. Yeah. My hope is that we kind of change the way that we manage those patients. What do you think is going to happen in the future?
That's what I hope too. I hope that it becomes more known that, supporting pregnancy health in patients with PCOS is extremely important. And it's not a fertility diagnosis, it's an endocrine disorder that affects absolutely everything and also affects future generations. So just looking at it differently, and hopefully the medical system will start to see PCOS a little bit differently and differently than just a fertility condition. And that's my hope.
So let's talk about the different typings of PCOS, because I think this is where we can run into a little bit of trouble, especially with like online information and misinformation about PCOS. Because now we're seeing women that like either self-diagnose because they're like, okay, I have that, I have that, I have that. And they come in saying, I'm pretty sure I have PCOS. But we're talking about like PCOS can show up so differently in each individual. Let's talk a little bit about PCOS typing. Like, what is that? And do we think that's helping us right now to be able to like stratify people based on their type of PCOS?
I think there's a lot of confusion around PCOS. And I think just like we said before, there was the underdiagnosis before, and now there's an overdiagnosis and a lot of misunderstanding around what PCOS is. And I think when it comes down to it, we have to think of PCOS as a condition of androgen excess. The Androgen Excess Society says that this must be there to have PCOS, whereas the Rotterdam Criteria, which are older, actually allow there to be that not to be involved. So the 3 Rotterdam criteria are, anovulation, which is periods that are far apart, polycystic ovaries on ultrasound, or androgen excess, which is either clinical or in the lab. And Rotterdam says you need to have 2 of the 3, whereas the Androgen Excess Society says you must have androgen excess and 1 of the polycystic ovaries on ultrasound or the cycles that are far apart. I tend to agree with the Androgen Excess Society because PCOS is a condition of androgen excess at its core. And then what we'll see is variations of that effect, and that affects people differently in different ways at different times in their life. And so I always look at it very individually. So sometimes people may have high adrenal androgens, especially when they're younger or if they're lean. I always take that into consideration, but I also look at everything else too. Are they ovulating? Are they, are they trying to conceive, for example? Like, what are the specific concerns that they have that they want to work on? So I think in my opinion, like, it's always very individual. I always look at the entire picture. What is the goal of the patient? What life stage are they at? Are they, in perimenopause? This is a very different situation than, someone who's 20 who has PCOS. So I find, sometimes it can be very confusing, some of the information. And so my goal is really to, try to help people understand the core central part of PCOS is androgen excess, and then everything else is quite individual. I would say there is a very big difference between lean PCOS and what we would call classic PCOS. And the difference between those two is insulin resistance. There are a lot of patients out there who have lean PCOS and don't have a lot of insulin resistance, and they're following a lot of restrictive diets, thinking that that's going to help them, and it's really not making a difference at all. And in fact, maybe making them worse. So it is really about understanding, that situation for that individual. And then also knowing if that patient gets pregnant, then they might become very insulin resistant because pregnancy creates that. So I really believe strongly that PCOS should be looked at individually, and always needs to be reassessed at every different stage in life.
Yeah, I very much agree. And so just to clarify for our audience, when you say androgen excess, can you give some examples of how that shows up in someone's life?
Yes. So androgens are a category of hormones, as you know, like testosterone and all of the friends of testosterone. So these are hormones like androstenedione, DHEAS. This is from the adrenals. These hormones have effects that can, in females, cause hair growth, unwanted hair growth on the face. So that's called hirsutism, so often on the chin area, and hair loss, which is typically more on the top of the head, and the part will widen. This is a very slow, gradual hair loss, not a rapid shedding in most cases. And acne is another symptom that we'll tend to see. But androgen excess can cause a lot of other symptoms as well. For example, like deepening of the voice, and even we know the brain will be affected by androgen excess as well. So it has a lot of different effects on the body.
It's interesting. I saw one study, and now I feel like it's just coming to mind, and I don't want to misquote it, but looked at some of the cognitive function in people with PCOS versus people without. And it was interesting that because we do have some estrogen dominant kind of behaviors and thoughts in our brain around multitasking, and parts of executive function are really driven by estrogen. And it was interesting that those parts of the people with PCOS couldn't pass parts of the testing around those cognitive functions because their testosterone was really high, but yet they didn't excel at the what we would call the classical male dominating cognitive functions either. So it was these PCOS people, you could imagine them sitting in not being able to excel cognitively from an estrogen perspective, but they also didn't excel in a testosterone perspective. I think I'm curious around how that relates to some of the mood challenges that we see in people with PCOS.
Yeah, it is super interesting. I love reading this kind of thing. And I know there is really some interesting evidence. Well, and even just clinically, I could say for sure, I definitely see a lot of my patients with PCOS are elite athletes. That's something I see all the time, especially, young women, very driven and very good at athletics. And then I also see a lot of CEOs, if I'm just thinking about my experience, very, go-getters and doing really well. And there is some interesting info on, I think it's visual spatial cognition is improved in PCOS. I think that the effects on the brain depend on a lot of different things too. It depends on the degree of androgen excess at puberty. It depends on if they're ovulating, because then they, if they're not, there's no progesterone, which is calming. And then in many patients, some of them, you probably have seen this too. Some have very low estrogen, whereas others don't, so there's a lot of variation there, I find, but there's definitely differences because of all of those different things in patients. Another interesting thing is that there's an increase in difficulty with impulse control that's been noted, and this has been associated possibly to binge eating and eating disorders as well. So really interesting stuff, and I'm hopeful that they will be doing a lot more looking at that in the future.
It's so fascinating. I have had a couple of elite athletes that are like, but wait, if we fix like this part, is it going to ruin this part? Like thinking about their sport.
Right.
Yeah, I find that that's so fascinating. And I think that where I've struggled with the typing with PCOS is partly with our accumulation of research over the last 30 years, because, and now like as a listener, you can probably imagine like if our diagnostic criteria was that you had to be overweight, have cysts on ultrasound, and have insulin resistance, and that's how we decided who we studied,
Yes.
we obviously missed a lot of people who struggle with PCOS in research for years.
100%. Yes, the research itself is on the wrong, it doesn't encompass properly because, and even if you read it, sometimes I'm like, I don't know if that's PCOS. Like they'll have the non-androgenic group in there, and I'm like, what's that? So it's even in research. I feel like sometimes it's not fully understood, and so there's still a lot to be done, both from an awareness standpoint and really like just understanding the impacts of like endocrine disruption on the brain, and then how to study that properly because I think it's really challenging.
Yeah, and I always get concerned about like the ripple effect of those things, right? Because like no one is looking at an Instagram post with a critical appraisal hat on going, well, did they include the people who have insulin resistance? Did they include the people who have androgen excess in that post? And when women are seeking solutions and seeking hope, it's very easy to get kind of misguided or even to feel hopeless because the information that lands across your desk or on your news feed is not actually about you. And it's actually not that accurate. And yet, because you have this label that either you've given yourself or someone else maybe has misassigned you, now you feel connected to this like research, but the research is not particularly good either.
Yeah.
It's a bit of a mess.
It is quite a mess. Yes, yes. And the other new mess is that a lot of overdiagnosis based on the ultrasounds. I know that as NDs, we know about this, but maybe some of the patients don't. But like the new ultrasounds are really good at picking up follicles. Like they're just so high tech. And a lot of patients who are in like a mild endocrine disruption, meaning that something's changed with their hormones for some reason. For example, stopping the birth control pill is a good example. Or like a huge amount of stress, something like this can cause our hormones to change temporarily, and if you were to ultrasound the ovary at that particular time, you can see something that looks like PCOS, a polycystic ovary ultrasound. But then these patients are sometimes being diagnosed based just on this. And then, this is causing more confusion as well with overdiagnosing. And many teenagers, if you do an ultrasound on their ovaries, will have PCO ovaries. And then this resolves as they get older. So it's super, super confusing, I would say.
And I think the harm there comes from, if we take it that one step further, the harm there comes from the idea that we've classically treated classical PCOS with calorie restriction and with low carbohydrate diets and with dietary elimination. And yet that really doesn't apply to that lean type patient, especially the lean patient who only has cysts on their ovaries, but no other symptoms. And now we're giving those people a restrictive diet. Like that's creating another endocrine disruption by putting a young, lean patient on a calorie restricted diet. Like that actually complicates their hormones more than it solves them.
Exactly. Yes. Because, if you type in PCOS diet, everything, and you're told, oh, I've got this ultrasound. Okay, I need to know what to eat. And you type that in, you get all these really restrictive diets that are aimed more at insulin resistance. And that may work. Yeah, exactly for those people. But this actually can do a lot of harm in the wrong person. So it is something that I really hope to clarify. I have created something called the cycle of PCOS, which talks about how insulin fits into the cycle, and it's sort of on the side. It influences it, and anyone who has PCOS is more likely to develop that when challenged, but not everybody has it currently to a great degree. So that always does need to be assessed because super important to treat, but also treating it when it's not there can do more harm than good.
Okay. I love the way that you said that. That's really helpful. And I think when we think about the different life stages of PCOS, this is something that I personally have an interest in like how we manage women as they age with PCOS. I know that's something that you're interested in too. I think we've been laser focused on the fertility aspect of PCOS because like that's the thing that can't happen easily or maybe won't happen easily when patients have PCOS. And that was often women's first point of diagnosis is like, okay, well, now they're ready to get pregnant. Now they come off the pill that was maybe helping their acne all along. And now we give them a real diagnosis and now they can't get pregnant. But we have an aging population of women with PCOS that now are approaching their perimenopause years. Can we just talk about that for a minute and why that is such an important stage to still recognize their condition?
Oh yeah, 100%. And like most NDs, I think I am always interested in what I'm going through myself. And I'm in perimenopause, I'm almost 47. So I feel all of those things happening in my own body. And now, of course, I'm very interested in all of this as well. So absolutely, like it's a very, what they find is we do see the androgens go down a lot, compared to like, when a patient is 25 as opposed to 45, obviously their testosterone is much lower because androgens decrease with age. And that's very common. But patients with PCOS, it's still higher than other patients. And then you add into that all of those endocrine changes that we see in perimenopause. So the fluctuating estrogen goes high and low randomly. Cycles become irregular, cycles become closer together. There's less progesterone, and less progesterone in PCOS is not a good thing because progesterone keeps the androgens in check by lowering LH. And so sometimes what we'll see at perimenopause is another raise of androgens again, or androgenic symptoms. This is for a few reasons. One is that the progesterone might be less. The second is the adrenals in PCOS do make a little rise of DHEAS in perimenopause in a lot of patients. And then secondly, like when the estrogen goes away, we don't have the opposing effects of that. So a lot of our patients will start developing hair loss is a really common one, acne and hirsutism. And then the insulin resistance gets worse because all of the same things that happen to everyone with perimenopause, the protective effects of estrogen and progesterone on insulin resistance. So yeah, we definitely see a very unique kind of picture in PCOS, a more androgenic kind of insulin resistant presentation.
And there's such an opportunity there for people to have that preventative approach to their condition that I feel like we're missing, right? If we don't sort of educate, because we've laser focused on what happens in those fertile years, that when women move past that no one's watching or managing their PCOS. And then we seem like surprised when their cholesterol levels are elevated at 43 years old and go, oh, that must be genetic, right? And then we start to like misascribe the experience they're having to something other than their PCOS, right? Which is really not doing them any favors.
Yeah.
And also can make people feel pretty helpless during that life stage.
Totally. And then the thing, yeah, exactly. And like everyone is almost undiagnosed because by that age, I mean, let's say you get to 40, and most women with PCOS are ovulating by 40. Like just because their androgens have gone down, it's quite rare not to be. Now they're undiagnosed because they don't fit the criteria anymore. And most don't have the polycystic ovaries. They might still have the androgen symptoms now, but that doesn't qualify for this diagnosis anymore. Now, do we just say, oh, no, now you're done. You don't have PCOS. But that's not true because these patients still have androgen excess compared to another person. So that is really problematic because there's a feeling like, oh, I'm done with that. But no, if patients know that this is still something to address and to just sort of understand like the unique hormonal signatures that we see, a lot can be done, and we can still prevent and do so much.
So where is the research going with PCOS? And I know, I think I feel the same way that you are. Like we're converging on some very positive things, right?
Yes.
The diagnostic criteria is getting clearer. I think we're doing a better job at figuring out who's going to benefit from what kind of treatment or what kind of support. We're seeing some conversations in the world of nutrition with PCOS saying, you know what, maybe it's not just about caloric restriction, maybe it's about diet quality and supporting patients in a more, I'm going to call it holistic way, rather than just talking about weight loss. But where do you feel like things are going to go over the next like 10 to 15 years as we talk about PCOS?
My hope is that it goes from, fetus to postmenopause, that we have, an understanding of how to support patients with PCOS through their entire lifespan, and, that it's individual, because, patients who have PCOS, we know, have like different kinds of mood disorders. They are faced with a lot of different stressors. They might have a fertility journey to go on through their life, and having to deal with a lot of things that, society is very judgmental over, having hair growth on your face and acne. And so the stress is there. And there's not that understanding in the medical community about like how to treat it holistically, and how patients need that overall support for every element around their health. So my hope is that with more personalized medicine, individualized medicine, that we're going to see PCOS seen differently. When a patient is diagnosed, that we'll have better pregnancy care, better care for mental health, nutrition, exercise support, and support through menopause and later life too. So that is my hope, that it will be seen differently and more as a disorder that affects the entire body.
And do you see any, or do you have any hopes on like the medication and the supplements? I'm going to kind of loop them all together in there. Do you see any hope on the forefront there as far as the research goes? Like, where do you think things are going to go in that regard?
I think there's a lot of really good research on many different supplements for PCOS, which I view as helpful in addition to everything else that we should do to take care of ourselves. When it comes to things like sleep, exercise, nutrition, as naturopathic doctors, these are our foundations always, and these make the biggest difference. And then supplements can help as well. So there are some really good supplements like the inositols and acetylcysteine. Medication wise, the go-tos in conventional medicine have been metformin, birth control pills. So my hope is that things like birth control pills will find some different alternatives, because sometimes they're great, and sometimes they're just not. And there are some other options out there. I use a lot of cyclic progesterone in my practice. I find it very, very effective. So I really hope that that will become more widely used, because I see really great results with my patients with that. So Dr. Jerry Lynn Pryor at UBC has been doing quite a bit of research on that. So I hope that that will become available more widely for patients. So yeah, and I believe as well there may be some new strategies that we can implement around insulin resistance in the future too. So I'm looking forward to that.
Yeah, I agree with you. I'm curious to see, like, we kind of, and not like metformin has its role and time and place and has done lots of good things for lots of patients. I'm curious, as we evolve more strategies for managing insulin resistance and diabetes, whether or not we can adopt some of those medications for our patients in like their middle life stages around their PCOS. But I haven't seen us like be particularly interested in trying that yet, but maybe we'll see that over the next 10 years or so. Last question for you, Fiona. If you were going to rewrite your book, what's the missing chapter? Like, what would be the chapter that you would add at this point? Like, knowing what you know now, having worked with thousands of people and women with PCOS, what would be that addition that you would want to make if you were going to add to your book?
I would definitely, add a couple of things. One is that I would include a lot about epigenetics, because when I wrote it, it was 2016. I can't believe it was that long ago. And we didn't know that much about this at the time. And so I would definitely include that, because I think a lot of patients, they just don't know that. And once they learn it, they're like, oh my gosh, I can do so much, to help future generations, to help my children. So I would definitely include that. I would also include some sections on cyclic progesterone as well, just because I've been using that frequently in my practice since that time and have seen clinically amazing results with it. So I would include those as well.
Awesome. Thank you so much for sharing. Where can our listeners find you? And we've got all the links to all the things in the show notes. Where's the best place to interact with like you and all of the information that you provide?
Yeah, I'm on Instagram at Dr. Fiona ND. And I own White Lotus Integrative Medicine, which is a clinic in Toronto. We practice primarily focusing on endocrine conditions like PCOS, thyroid, fertility, and menopause and perimenopause.
Awesome. Thank you so much for hanging out with me today.
Thank you so much for having me. It's been an honor.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.